change.
Sorry.
No, thank you. And if you want to change your name to just a first name or anything like that, feel free to do whatever you're comfortable with. Thank you for recording. Well, on behalf of the IWMF, welcome WMers from across the nation. I'm Lisa Wise, a WM patient of 10 years and the support group leader of Eastern Pennsylvania and Southern New Jersey. I am thrilled that you are all joining us for this exciting meeting. Everybody able to hear me okay? Can you give me a thumbs up if so far so good, no complaints? Excellent. Now that I know you know how to do that, feel free to give me a thumbs down when you've had enough and you want to move on. Christina Bach presented to our fabulous Philly support group last year. And we loved her so much that we wanted to have her return so we could share her with all of you today, and that's what's happening today. Just a quick reminder to everybody to please mute themselves so that we can be sure that we can hear each other. Philly support group members who know Christina, let's give these folks a big Philly welcome wave. So let a little WM love shine across our beautiful nation today. Come on, Philly. There we go. I love it. I love it. There we all are. Christina Bach is a clinical oncology certified social worker, a medical social work ethicist, and a national leader in the field of financial toxicity and navigation in the cancer world. I had the pleasure of meeting her as the psychosocial content editor at Oncolund, which is the web's first cancer education website. This year, in 2020, Christina was given the American Cancer Society Association of Oncology Social Work Quality of Life in Cancer Care Award. Christina is also an instructor at the University of Pennsylvania School of Social Policy and Practice. But to really know Christina's heart, you have to know her two loving therapy dogs, Linus and Huckleberry, who volunteer their services at Penn Medicine. Now listen, I know what you're all thinking, okay? No one can make the topic of health insurance fun, right? This is what you're thinking. Wait until you meet Christina. I am not ashamed to admit to you all that I am the least financial savvy person on the planet, and I need things explained to me like I am a fourth grader. I'm not kidding. With Christina in the room, I feel like a financial genius. I walk away understanding so much more and appreciating the richer complexities. Christina's vast knowledge, impressive expertise, and engaging style is a gift. I just want to say a word of thanks, a word about Carl Harrington. I know you all know Carl Harrington. He's going to be ending his many years of tireless service as the IWMF board chair. If you have ever enjoyed an ed forum, or maybe gone to a support group, or benefited from any research in WM, or called Lifeline, or downloaded a WM FAQ, or checked out one of the videos in the library on the IWMF website, you have Carl to thank for that because his fingerprints are on everything IWMF. So join me in clapping thank you to Carl, an enormous, deepest bow to him. Enormous thanks to Pete Denardis, our beloved moderator of IW Connect for many years, who will soon step in to the exciting role of chair. I also want to express a word of thanks to my partner in WM Crime, Michelle Postic, the IWMF's amazing manager of support and information. There she is, waving. Reach out to Shelly and I anytime. We love hearing from you. We are here for you, and we want to help. I want to review 4 guidelines for today's call, and then we're going to begin our program promptly. Number 1. Thank you for submitting all of your questions in advance. We received over 30 terrific questions. Christina has incorporated her responses into the whole slide presentation. And in a minute, Christina is going to offer guidance on how to use the chat box today if you've got things you want to know. Number 2, we are going to be a large group. So we'll need to mute everyone so that we can hear Christina without any background noise. I'm sorry about that, but hopefully we'll have a chance to unmute later on a bit. If you need to move around, stretch your back, get some snacks, or take a bio break, please do so. The IWMF believes strongly in self-care. It is a very good thing indeed. Just do us a favor, turn your camera off to avoid distracting others while you're doing the yoga poses. Thank you. And lastly, our meeting will wrap up at 4 p.m. I'll be hanging out to connect and schmooze afterwards, so feel free to hop off this call anytime you need to when life calls, or stick around and say hi afterwards. The choice is totally yours. It's now my honor and pleasure to invite the wonderful IWMF CEO and President, Newton Guerin, to say a few words of welcome to you all. And after he's done, I'm going to introduce Christina. Newton, hi.
Hey, thank you, Lisa. And I promise I will be very, very brief. Lisa made me swear to that. So first of all, I'm just delighted to be here with you and see all of you. The last I looked, there are 52 participants from throughout the country. I certainly think that is clear evidence that the good work that Lisa has done in organizing and putting this webinar together, and the presentation that Christina is about to make. Obviously, this is an important topic. It's very timely. It's important to all of us, and I'm delighted to be here and have the opportunity to learn along with everyone else. So that's really all I had to say. Just thank you for participating, and I'm sure this will be a great experience. And I look forward to meeting you all face to face one day, I hope real soon. So Lisa, thanks again.
Thanks so much, Newton. We're so thrilled that you're here with us today, and thanks for your inspiring leadership always. We appreciate it deeply. Well, it is an honor and a joy to extend my warmest welcome and heartfelt thanks to the extraordinary Christina Bach for being here today. Christina, my friend, take it away, and thank you, thank you, thank you.
I think I was looking around because I'm like, you can't possibly be talking about me. Weird. I also wanted to take a moment just to introduce Ming Toy Lamar, who is a social work student who is doing her internship this year with me. She's at the Bryn Mawr School of Social Work. It has a really long name, Graduate School of Social Work and Social Research, and I don't even know. But part of what you do when you learn to be a social worker is you do 2 years in internship. And so she is spending this year as interning with me and getting to do lots of really interesting projects and getting to know more about the oncology social work world. So I have spent the last nearly year and then my part-time gig finally getting paid for doing financial navigation, which I've sort of done on the sly for many, many years. But I now work part-time for the Cancer Support Community Helpline. So I did include their number as a resource later. If folks don't get their questions answered today, and need more resources, it's a great place to start, and you can get referred to me for additional, more individually focused financial navigation services if that's something that you feel like you need. That's free of charge to you, but I am available for individual consultations through that helpline. So we did have a lot of fun. We talked about insurance last year. I'm not sure if that was because it was the first day that the Eagles were playing last year and we were all kind of jazzed up about a hopeful year with the Birds. Not so hopeful this year, but we're on the bye, so we can't lose today. So that's good. So I'm excited. I love to talk about insurance. I never thought I would love to talk about insurance, but if there's one thing I've come to learn in the time I've been doing financial navigation and really advocating about the issue of financial toxicity is that we don't have a clue how our insurance works. And I am 1000% guilty of that as well. I have to look things up a lot. I just had a bill that I got that a service was denied and my EOB, and I couldn't figure out why. And it was because the x-rays were bundled in with the orthopedic visit. But I had to know how to read that language to understand that even though the explanation of benefits form said denied, in reality, it was paid under a different bundled payment. So they haven't made it easy for us. It is like learning a foreign language. And the other thing is that it kind of is changing all the time. And so there's one thing I can tell you to take away is now is the reason we decided to do this now too, and I pushed Lisa on this, and I'm so grateful that you you fit me in, is that it is open enrollment right now for Medicare Advantage, and for the Affordable Care Act. So this is a really good time. Also, if you have employer-sponsored plans, commercial plans, many of you might be in open enrollment right now as well, because you run on the calendar year. And so your benefits may be restarting again in January. So this is a really good time to be talking about, how do I make changes? What kind of changes do I want to make? How do I know if I need to make changes? And what kind of knowledge do I have to need to do that? So I am going to share my screen, and there will be a delay, a lag. In the interim, I'm going to do my poll, my first poll. Bear with me because I have not done this before, and I have a bunch of poll questions, so I'm hoping it doesn't launch all of them at once. So I'm going to ask my first question, which is, what was your motivation for attending this session? So just answer question 1 if you would right now. Okay. I don't know that that worked. Did that work for anybody? No? Poop. All right. Trouble.
A little more time.
Okay, let me relaunch it again.
Yeah, it looked like you might have to answer them all at once and then submit.
I see.
Exactly.
Oh, boo. Okay. Okay, well, let's do that. Let's go ahead and do a pre-quiz. How about that? And use this as a pre-quiz. And then I'll be able to kind of look at it throughout the course of the time that we're together today. So much for my great plans and my highlighted sheets of when to ask questions. I'll just put that in the round file. So let's take a couple minutes to do that. Good, I'm seeing answers starting to show up now. Thank you.
I think you get the prize for the most letters after your name.
Yeah, it's alphabet soup.
I'm impressed.
Thank you. I'm going to let it go for about 40 more seconds. That's 3 minutes. If you need more time, though, please let me or Lisa know. I appreciate, this is really great information, so I appreciate you all responding. It's wonderful.
Someone in the chat stated that the supplement plan F has closed.
Yeah, I'm going to talk about supplement plan F when we talk about Medigap plans. I'm just making a few notes. Okay. Okay, does anyone need more time? Okay, great. I'm going to end the poll. And are you all interested in seeing the results? I can share them anonymously with you. So, and for all of you on question 1 who entered, what is your motivation for attending? If you want to put that into the chat box. I was trying to see if there were any others. Nope, no others. So I'm going to go ahead and share those results with you so you all can take a look. I definitely wrote down ones that stuck out to me that I'll talk about today during our time together. Lisa, do I need to scroll for you to see all the results, or do you guys get those yourselves?
So I'm not seeing that. Are folks seeing that?
Uh-huh.
They are? Okay.
Yeah, so are you seeing
Yes.
that here on my screen? Government provided plan was the highest.
Yes.
Okay, great.
I am now. Sorry. Yes, we
This
can
one
see.
is something we're going to talk about, which is really interesting to me that 34 of you said you don't know what your MOOP is, which is a really, really important thing. And also that there's a fair number of you that don't know if your providers are in network. And that's also a really huge issue that comes up. And oftentimes we don't know about it until after we've had a service provided, and then we're really out of luck. I see a lot of you do want to make changes during open enrollment. This is also really telling to me that we just don't know how much our medications are going to cost. I'm going to show you a pretty cool tool that's available to all of you on Medicare.gov, so you can see more about the cost of your meds. And also that there's just not a ton of you that are utilizing financial assistance through copay assistance organizations. So it's really interesting. Thank you for doing that today. All right, now let's go to the slideshow. All right, there we go. Lisa, I fixed the lag problem by unplugging my second monitor, which makes all the difference. So, but clearly I need to go to how to do polls school. So, let's get started. Let's dive in a little bit. I like to start with the basics, the beginning here, which is what is health insurance? I got to find out where to put you guys so that I can see my slides. So it's a financial protection against medical expenses if you have an accident or a major illness. I want to focus on the next part on the fact that it is a contract between you, the insured, and your insurance company. This is actually going to be really important in the coming year, in particular, with the ACA case coming up to the Supreme Court this year. What I am telling folks is we are selling plans for 2021, okay? That is a contract that you are entering into with your insurance company. And as long as you pay your premiums, that contract should exist for this year. We're going to get to talking a little bit more about the ACA a little later on. Usually the way insurance works is you have a provider of services, a healthcare provider. They submit a claim to the insurance company for the services provider. I wish it was that easy. And I wish that there was like a price tag that was like, this colonoscopy is $38 everywhere and for everyone. Or this pill is 17 cents for everywhere and everyone. But the truth of the matter is that every payer has a different contract with every provider that they have negotiated. And that's where that in-network thing really comes to be important. There's also some plans, and we've seen this go really sort of out of usage, but very much used in the behavioral health setting. So anytime you're going for counseling with a social worker or a therapist, a lot of times they are not in network, and they will provide you with paperwork, and you'll pay out of pocket and submit to the insurance company with documentation for reimbursement. It used to be that more medical services were provided in a similar way, but we've really moved away from that so far. Any questions getting to get started? Just checking. Hi. All right, awesome. I see a couple comments, and I'm going to get to yours, Gary, and to Eric at some point today. Thank you. Okay, so why have health insurance? Well, accidents and illness happen all the time. Even if we're the healthiest, youngest, most strapping young person in the world, stuff happens, right? And so it's really important that we have sort of a backup plan to help cover things in the event that we have an accident or an illness. Now, with accidents, there's another caveat, which unfortunately I've had to learn a lot about in the last few months, which is the coverage of injuries related to automobile accidents, which is under your car insurance for a certain part. So I'm not going to talk about car insurance and automobile accidents, but when I talk about accidents, I mean, maybe you cut yourself with a knife at home while you're making dinner tonight. That's an accident. Really important to remember too that unfortunately in our country, medical debt is the #1 cause of personal bankruptcy. And my sister is a bankruptcy attorney, and she and I talk a lot about this. And she says, I feel badly that folks are using bankruptcy as their only way to get out of this medical debt that they had no choice other than to be sick or to die to incur. It seems like it's not fair. So one of the things that sucks, I definitely have done bankruptcy counseling with people in my role on the helpline, and I try to really get them to think about all the possible other alternatives before thinking about personal bankruptcy. Insurance companies also help to give us access to networks of doctors and hospitals. They negotiate as a group, and that as a goal should be lowering costs with insurance companies. It's a safeguard for our quality of life and our physical and financial well-being. And certainly how much insurance we have or how much we pay for insurance is really tied to something that I like to talk about in terms of what risk do we feel comfortable with? Are you risk averse or are you risk tolerant? So for me, I'm pretty risk averse. So I'm probably going to buy the Cadillac plan on the front end, knowing that I have what I need and I won't have to pay a lot on the back end if I do get sick. But on the alternative side of this is the risk tolerant person who might say, you know what, I'm okay right now. I'm pretty healthy. I'm young, don't have a lot of family history. I'm going to pay the lower premium on the front end, roll the dice, hope I don't get sick. If I do, I know I'm going to have some higher out of pockets on the back end. Now that risk tolerance is something that is a very personal thing. And I find it very interesting also that we're seeing parallels to our risk tolerance in terms of learning how to live with COVID-19. Certainly we have some people who are like, I'm more risk tolerant, so I'm going to go out to eat at a restaurant outside without a mask on. And then we have other people who are really risk averse and are not leaving their homes, having all of their stuff delivered to them. And so it's very interesting to me, the parallels between risk tolerance that we see in various parts of our lives. Totally applies to health insurance as well. So there's 4 basic types of insurance, okay? There are private or individual plans. Yes, you can call up to, and I'll use a Pennsylvania example, Independence Blue Cross and say, hi, this is Christina. I'd like to buy an individual plan. And they would sell me one. They'd ask me a lot of questions about what I was looking for and give me options in terms of deductibles, how much I wanted to pay a month, where I wanted to go for care, but you absolutely can call up to an insurance company and buy an individual plan. Most of us in this country, though, do have coverage through either employer or union sponsored or provided plans. That's where my insurance comes from working at Penn Medicine. or from government provided plans, which includes anything from the Veterans Administration, TRICARE, if you have Medicare, Medicare Advantage, Medicaid, those are all government provided plans. So even though you hear no government in my insurance, they're already there and they're already running insurance for a whole lot of people. And then finally, we have the ACA or healthcare marketplace plans. In Pennsylvania this year, it's the first year we are going to have our own healthcare exchange. It's called Penny. And what's great about it is it's going to be open a little bit longer than healthcare.gov exchanges. So our residents in Pennsylvania will have longer to enroll in plans for 2021. But we're still kind of getting that data out to see what those plans are going to look like. Every state has, if they are in the healthcare marketplace, so they go through healthcare.gov to sell their ACA plans. Their open enrollment is now until December 15th. There are some states that offer their own exchanges like Pennsylvania, New York, California, and they're going to have later deadlines for their open enrollment. Okay, so my number one tip to all of you, and the way that you answered the question about your MOOP certainly shows me that we have to do a really, really good job of learning to speak the language of health insurance. And so this is your homework assignment tonight, everyone. Well, not necessarily tonight, but maybe for the coming week, is I want you to get out a piece of paper, do your Excel spreadsheet, do this on your phone. But I really want you to go through each of these terms with each of your plans and know what we're talking about when it comes to your plan. So number one is your copays. Now this information you likely can find on your insurance card. On the front of your card, it will usually say copay, office visit copay, primary care doctor, specialist, and sometimes they have radiology or labs might be listed on there as well. So in my card, for example, it says that my copay for my PCP, my primary care doctor, is $20. But my copay for a specialist is $50. That's a big difference. And if any of you are seeing specialists, and I know you are because you're all seeing oncologists, other specialists, you're paying that specialist copay for every visit that you have. Now, copays differ from co-insurance. This is the cost sharing amount that you pay as part of your coverage. I'll use Medicare for an example. Medicare A and B, so no supplemental plan, is an 80-20 plan. That means with Medicare Part B that they pay 80% of your charges and you are responsible for 20% of your charges. Other commercial plans, like employer plans, have co-insurances as well. So again, for example, for me, again, I'm a Penn Medicine employee. If I use a Penn Medicine provider, my co-insurance is $0. As soon as I go to a provider, let's say at another hospital in Philadelphia, my co-insurance is 80-20. And if I go out of network, it's 70-30. Okay, so it can change in lots of different ways, and you might have different co-insurances. Even though you have one insurance plan, you may have 3 different co-insurance amounts. That's where the MOOP, the maximum out of pocket, is really important. Because with most plans, once you've reached a maximum out of pocket for the year, your plan then covers that co-insurance at 100%. The exceptions are Medicare and out-of-network providers. Usually with Medicare, if you don't have a gap plan, there is no maximum out of pocket. You will always pay 20% for all the costs of your care if you do not have a Medigap plan. With out-of-network providers, that money that you pay for out-of-network providers typically does not count towards your maximum out-of-pocket every year. So you really have to be able to pay attention to who your providers are and if they are in network or not. Any questions about co-insurance and MOOP so far? I'm gonna have some water. Okay. I'm assuming no questions means we're doing good with explaining things. So our premium, that's the amount of money that you pay for your insurance plan. So let's again go to Medicare. If you've paid into Medicare through Medicare taxes, you don't have a monthly premium for Part A. You do have a monthly premium for Part B, and you would potentially have a monthly premium for a GAP plan and for a Part D plan that you would buy. Premiums do not count towards the maximum out of pocket. They also do not count towards your deductible. And your deductible is the amount of money that you pay for your insurance before it starts to cover any costs. And again, you really should know what your deductible, if you have an employer plan or an ACA plan now, this is really being a trend where we've seen deductibles really skyrocketing. It is not out of the norm for me to see deductibles of $6,000, $7,000, $8,000, $10,000 of personal expense before your insurance kicks in. And cost sharing is the contribution you pay towards your healthcare costs out of your own pocket. So that is the total amount of your deductibles, your co-insurance, and your co-payments or similar charges. Those expenses, deductibles, co-insurance, co-payments, count towards that maximum out of pocket. But premiums, balance billing from non-network providers, or the cost of non-covered services do not count towards your maximum out of pocket. Don't like that. Okay. Other couple key terms that I think are really important to know is prior authorization. I'm working with a couple of clients on the helpline right now that had CAT scans that didn't get prior authorized before they had the scans. And guess what? They got a bill. So if you're having scans done or you're having tests done and you're worried about if they're going to be covered, be sure to be asking your provider's office if they have gotten approval from the health plan before you have the test done. I had an MRI a few weeks ago, and I didn't even do this for myself. I got home from the MRI, and sure enough, there was a letter from my payer that said that the MRI had been approved. But I was really kicking myself as I was laying there in the MRI machine going, I didn't ask if this had been prior authorized. So be sure to ask beforehand. I can't tell you enough, like, just to get that information. And if you also can ask the person at the front desk or at your provider's office who's doing the prior auth, if they have a number that is assigned to that case. That is also something that can be really helpful for us as well. And interchangeable terms used in that space are prior authorization, pre-certification, or prior approval. Whatever information you can get to back up your claims that these services that were ordered were prior authorized will help if down the line it is denied. Okay. So a benefit year is the year of benefits coverage under an individual health insurance plan. So this can be variable. For Medicare and ACA plans, the benefit year starts in January. For many employer plans, like mine again, our benefit year starts in July. We run on the fiscal year. And even more in the weeds, some people's insurance plans are tied to their employment date, or their employer does open enrollment and their benefit year starts in October or March. The reason I tell you that it's important to know what your benefit year is because your deductibles and your MOOPs, your maximum out of pockets, reset every year at the start of your benefit year. So it's really important that you know when your benefit year starts. This is a really tough time of year to get sick. I always say in October or November, because maybe you've been healthy this whole year and now you get sick at the end of the year and you pay your $5,000 deductible, and guess what you get to do in January again? Pay your $5,000 deductible, and it hurts hard. So it's really important to understand what that benefit year looks like. I also just wanted to highlight for benefit period. This is a Medicare only term, okay? So if you don't have Medicare, take a drink, have a Reese's peanut butter cup, take a bio break for a second. For a benefit period, this is a benefit period begins the day that you are admitted as an inpatient to a hospital or a skilled nursing facility. That's what a SNF is. The benefit period ends when you haven't gotten any inpatient hospital or SNF care for 60 days in a row. You must pay the inpatient hospital deductible for each benefit period. There's no limit to the number of benefit periods. So this means that if you go into the hospital and on day 62 after your original hospital stay, you go back in, you have to pay the inpatient hospital deductible again. This happened to my family with my grandmother, who broke her hip April 1st and was in the hospital, then went to a skilled nursing facility, then was home for a while. And then on September 1st, she fell and broke her other hip, which meant we had to pay her hospital deductible all over again. So again, it's really important to know that and to know when you've been utilizing your inpatient care with Medicare. Other key terms: denial. This is a refusal by the insurance company to honor the request by the individual to pay for healthcare services obtained, ordered, or requested. I think that most of the time we see denials happening either A, because they weren't prior authorized, which I just talked about, or B, because the insurance company feels there are cheaper tests or cheaper things that could be done first before they're going to approve the cost of that specific test or drug. So a lot of times we have to, some plans will not cover PET CT scans, which we use a lot in the oncology space. And they say, well, you have to have an MRI or a CAT scan first. But a lot of physicians say, but wait a minute, the MRI PET or the PET scan doesn't show the same thing as the MRI scan does. And we've had some success with appeals in that space, which is the request to the health insurer or plan to review the decision. And a lot of times we are able to get those overturned with like your doctor calling the physician at the insurance company and making a case, providing literature about the efficacy of a test or a treatment. So there are time limits though that are associated with denial. So if you do get a denial, it's important for you to communicate that with your healthcare team immediately. Let them know, hey doc, this test you wanted me to have, I got a denial. How should we move forward? Okay. Other really important thing is your formulary, and formularies change every year. Sometimes they change in the middle of the year. For example, this year, Zantac was on a whole lot of formularies, and then it got pulled off the market because it was found to contain some potentially cancer-causing ingredients. So it was removed from a lot of formularies. Also, new drugs happen. And so they can get added to formularies at various points during the year. So that's that list of prescription drugs that is covered by your plan. And usually within that formulary, there are tiers. And I know lots of you know about tiers because several of you asked me questions about that magic medication that many of you are on that is a tier 5 drug. So that's part of it. And then there's also step therapies. So let's use this as an example. There's a bronze, a silver, and a gold banana. The gold banana has more potassium in it than the bronze banana. And your doctor wants you to get the gold banana. But you have to prove to the insurance company that the bronze banana isn't just as good for you as the gold banana, even though we know the gold banana has more potential health benefits. So basically, insurance company says you got to fail the lower drug, the lower costing drug, in order for us to approve the higher costing drug. That's called step therapy. We see that a lot in management of diabetes, in management of cholesterolemia, in the management of pain. Big time use of step therapies there. And network, okay? And this goes back to that question I asked you. I know if my providers are in network. 80% of you said yes, and 20% of you said no. And the truth of the matter is that you may go to your provider, see your oncologist is in network, the oncologist does a bone marrow biopsy, they send the bone marrow biopsy to the pathologist reads the biopsy, but the pathologist is out of network. Yes, this happens. Just because your provider is in network doesn't mean that every physician or provider at that hospital is within network. So that is also a really important question to ask. Are all of the folks that are going to be laying eyes on this sample or providing me with care network providers that can provide me in-network rates? You have to ask these questions. So, any questions so far about the terms that you need to know? Does everybody have their homework assignments and know what they need to do to get their stuff in a row for open enrollment? Okay. So, open enrollment, that's where we are right now. It's our period each year when you can make changes to your health benefits if you have Medicare or Affordable Care Act plans. And you see our dates, it's running right now. I was happy with the ending of political advertising, but then what took its place was all this sort of advertising for Medicare Advantage plans that are driving me equally as bonkers as some of the political ads. So let's talk about what some of these plans look like a bit more. So what do I need to consider during open enrollment? Number one, what gaps do I have in my coverage? So doing that homework assignment I just gave you will help you to understand some of that and help you understand if there's changes that you can make to help fill those gaps, or if you're potentially creating new gaps. You want to know what is covered, but you also really want to know what isn't covered. You want to be able to best guesstimate what the costs are going to be. Make sure that you can see your healthcare providers and that they're going to be in network for the year to come. Just because they're in network now doesn't mean they're necessarily going to be in network in January. You also want to know where you can use your plan. And I know there's folks on this meeting from all over the country. And this actually really comes up as quite a challenge with ACA plans and with Medicare Advantage plans. And the reason is that they are tied to your geography. So if I buy an ACA plan in Pennsylvania, it's a Pennsylvania plan. I'm working with a client right now who bought an ACA plan in July, and now she wants to go to Boston for a second opinion with a surgeon. That is automatically an out-of-network cost because her ACA network is only in the Philadelphia area. The same thing happens with some Medicare Advantage plans. As you buy into a Medicare Advantage plan that is locally based, and so your network is local as well, and that can really have an impact on where you can use your plan. Versus if you have regular Medicare and you're a traveler like me, and you get sick when you're traveling, your Medicare network is more of a national network, something to think about. As well as how can I maximize my coverage and minimize my out-of-pocket? And then to ask that question of, am I risk averse or am I risk tolerant? What can I handle in regards to my risk with my health, my insurance, and my bottom line, my dollars? So if you miss open enrollment, there are several things that you can do. And this has actually really come up quite a bit during the pandemic. So if you have employer-sponsored coverage, certain life events like a marriage, divorce, or a birth of a child may make you eligible to make changes outside of open enrollment. Again, this is employer-specific, and each employer decides what constitutes a life-changing event. You have to ask Human Resources specifically. You may be able to make changes if your current Medigap or Part D plans stop offering coverage in your area. So this happens also. You purchase a plan during open enrollment, and then in April they decide, you know what, we're not going to provide services to this geographic area anymore. You will have the option to change your coverage at that time. Important to know, though, is that you cannot join a Medicare Advantage plan outside of open enrollment, where we are right now. So you've got till December 7th if you want to join a Medicare Advantage plan. You also cannot switch out of a Medicare Advantage plan during this time back to straight Medicare. So you can only join a Medicare Advantage plan or switch to a different one during open enrollment. You may be able to buy a supplemental plan or a Part D plan outside of open enrollment, but your costs may be higher. And this is where this has come up this year for us with the ACA. You may still be able to purchase an ACA plan if you experience a qualifying life event, a change in your life that will make you eligible for that special enrollment period. Well, we saw a ton of this with people who lost their jobs as a result of COVID, which automatically triggered a qualifying life event for folks and allowed them to buy coverage through the Affordable Care Act in their states outside of the open enrollment period. We've done a lot of work in this since March. Whew. Sorry. So let's start with unpacking Medicare. Just checking my time. I think we're doing great. So for those of you who are on Medicare, this might be a review, but I like to really unpack the different pieces of it. And again, this is really important if you're going on Medicare in the near future as well. So there are a bunch of different parts. Part A is your hospital coverage. Part B is your outpatient or ambulatory care coverage. Part C is a Medicare Advantage plan. You do not have to have a Part C if you have Part A and B. We'll get to Part C later. I'm not sure it should be called Part C. I think that's a little dubious. Part D is prescription drug coverage. And then there are supplemental or gap plans as well. So here's a little bit more of a breakdown of what's covered under Part A. Again, it's that inpatient hospital care. It's that care if you need to go to a skilled nursing facility for ongoing care, hospice care, and some elements of home health. Under Part B, this is where we're seeing that ambulatory care services, things that are done that are not in the hospital, like your outpatient services, your preventive care services, your colonoscopies, your mammograms. Some chemotherapy medications are covered under Part B. There's a special list of them, and the only reason they're covered under Part B and not under Part D is because they're available as both an IV and an oral drug. So they're always going to be billed under Part B. Mental health services, ambulance services, and durable medical equipment are also covered under Part B. Okay, looks like I have a question.
Yes, I'm sorry.
That's okay. Did you say that you cannot? So you can go back to Medicare once you have subscribed to a Medicare Advantage plan. Thank you for this great question, Cindy. Can you hold on for 1 second till I get to my slides on Medicare Advantage, and that way we'll make sure that we get you the right answer. Thank you, Cindy. Okay. All right, so here we are. Oh, look, it was the next slide, lo and behold. So Medicare Part C, this is how I'm gonna break it down for you. And this is how I tell this to people all the time. If you have a Medicare Part C, you have essentially sold your traditional Medicare, your red, white, and blue coverage card, to a private provider of insurance to manage your care. It is a type of healthcare plan that's offered by that private company. They contract with Medicare. They must provide all of the same benefits as Part A and Part B. And this is where your commercials come in that you're seeing probably right now, that they also have these enhanced benefits. People really latch on to these enhanced benefits of maybe vision, dental, transportation. I'm seeing home delivered meals being offered to certain folks with Medicare Advantage plans this year. I'm seeing attendant care or non-skilled care at home being offered. It's really plan dependent. It's really location dependent. Yes, those are augmented services that regular Medicare doesn't provide. They're usually HMOs, so they usually require you to choose a primary care provider who's going to be your gatekeeper, and you'll need referrals for all of your specialist care. And those co-pays for the specialist care can be much higher. This is a big difference between straight Medicare and Medicare Advantage. There's no specialist versus PCP provider difference with regular Medicare, but with Medicare Part C Advantage plans, there is. So you might pay $15 or $20 to see your primary care doctor, but I've seen co-pays as high as like $75, $80 for specialists. And if you're seeing a lot of specialists, or you're just seeing your oncologist and you're seeing them every couple of weeks, that can really add up quickly. Also, you may be capitated, which means you have to go to certain providers for labs or radiology, and that may not be at your cancer treatment center. And that can also be something that is kind of frustrating for your providers, I will tell you. They like to be able to send you downstairs to the lab or send you over to radiology to get your exams right on site, and then they can open everything up and look at it in the medical record, and everything is right there. But if you are capitated to go to a different lab outside of your system, that can result in a delay in your providers potentially getting your results. Finally, and this is what they don't tell you in the commercial, so please, please, please pay attention. Again, like I said at the beginning, they have to provide all of your Part A and Part B covered benefits. So coverage for all of your outpatient services is 80-20 until you reach an annual maximum out-of-pocket, your MOOP. And you cannot purchase a supplemental plan to cover that gap. So you have a gap, you're responsible for 20% until you reach your maximum out-of-pocket. And that maximum out-of-pocket varies from plan to plan, and again, location to location. And I will tell you that for 2021, the high end limit of what that maximum out of pocket can be was raised to $7,500. And I am seeing many, many plans who are adopting that maximum out of pocket. They don't tell you that on the commercials. Yeah, you're getting vision. Yeah, you're getting dental, but you're also paying 20% of your care until you reach your maximum out of pocket of $7,500. So your other services are going to cost you at least $7,500 for the course of the year. Okay, makes sense, everyone? That's what I want to scream at the television a lot when I see these commercials. That really upsets me. Okay, I keep trying to use my keyboard to move my slides and it's not working. So that's why I'm getting frustrated. But let me go back to your question, Cindy, about when you can and can't get on and off of Medicare Advantage plans. So you can get into a Medicare Advantage plan during open enrollment, and you can switch Medicare Advantage plans during open enrollment. However, you cannot disenroll and go back to straight Medicare until the Medicare Advantage disenrollment period, which is January to March. During that time, you can disenroll. So if you disenrolled in January, you would have straight Medicare again in February. If you disenrolled in February, you'd have straight Medicare again in March. Then you would still need to go ahead and purchase a GAP plan and a Part D plan, again, outside of open enrollment. Costs could be higher. It doesn't set you up really quite well. So this is one of the reasons I really caution people before they enroll in a Medicare Advantage plan. It's easy to get into one and they sound really good on the surface, but once you're in one, it can be hard to navigate through. Does that answer your question, Cindy?
Yes, thank you.
No problem. Okay, let's get into the weeds with Part D. So Part D, again, is prescription drug coverage. And I just want to give you a little history. Part D is not that old. It went into effect in 2006 and has had a lot of changes over the past 10 years as a result of the Affordable Care Act. And I say that to you now because I want everybody to be understanding that the Affordable Care Act and the potentials of what could happen with the Supreme Court hearing are not just about the exchanges. They affect pretty much all of us because it's completely changed the delivery of healthcare services. But let me unpack a little bit more about Medicare Part D. So you have a deductible, an initial coverage period, the famous donut hole, and then catastrophic coverage. These are the 4 periods of coverage under Medicare Part D. This is the chart of what it looks like for 2021. You can see the increases that were made. The deductible in 2020 was $435. That's being raised to $445. So again, you're responsible with a deductible for all of your costs. Plan pays nothing. Okay. Deductible only applies to tier 3 to 5 on most plans as well. This was something that happened as a result of the Affordable Care Act. So if you have a tier 1 or 2 drug, usually those are going to be covered even without the deductible. Then you enter into your initial coverage period, which is any dollar amount drug costs less than $4,130, and you will pay copays and co-insurance there. Then you go into the coverage gap or the donut hole. And again, I just want to say, whoever came up with this was a masochist. This is terrible. It's hard to understand. I don't understand how they possibly could have come up with such a confusing and difficult to navigate system. But in our coverage gap here, this is where you would pay 25% of the cost of the drug when the TROOP, which is the true outpatient cost of the medication for both you and the pharmaceutical company, is between $41.30 and $65.50. And then anything over the cost of a drug being greater than $65.50, that's called catastrophic, which I call a catastrophe for people with cancer, because you are stuck paying for the rest of the year the greater of 5% or $9.20 or $3.70 for brand name or generic. Now I say this, and I'm going to unpack this for you a little bit to show you why this is such a challenge for people with WM. So did you know that you can actually navigate your drug costs right on Medicare.gov? I apologize for the size of this, but this was the best that I could do to use my red arrows to show you where to go. So here we have, this is straight from Medicare.gov. You want to click on this portion here that says drug coverage Part D. And then you want to go down below to this section here where it says look for specific Medicare drug plan costs. And again, this is for if you have Medicare A and B and you're looking at a D plan, or if you have a Medicare Advantage plan, okay? You can also use this tool to search for supplements and other insurance like Medigap plans. This is actually a website the government has done a really, really good job with. So here you would then go to continue without logging in. I did not create an account. And if you wanted to look for Medigap policies, you could click here. Otherwise, you would just go to continue without logging in. And then it's going to ask you a few quick questions about what you're looking for. So I want to look for just a Part D plan for 2021. But if you wanted to look for an Advantage plan or a D and a Gap plan or just a Gap plan, you could enter that information in here as well. Oops, sorry.
We have a question too.
Yes, what's the question?
When switching from Advantage to Medigap, do pre-existing conditions apply?
And I see that we had, yeah. So the answer to that question is sometimes. And it depends on how much time is lapsed between when you disenroll from your Medigap plan and when you buy when you disenroll from your Advantage plan and when you buy a Medigap plan. There is a time period that you have, and I cannot remember the date, the amount of time off the top of my head. But if you buy outside of that period, then yes, they can look at medical underwriting. And just hold on to that for one more second, because I'm going to talk a little bit more about gap plans and medical underwriting and pre-existing conditions in a minute. Okay, so I've chosen drug plan, and then I've entered, this is my zip code here, and then you would press continue. And zip code, and this is, do you get help from any of these programs? So you would answer this, yes, I get Medicaid. If you get Medicaid, I'm on SSI. I'm in a Medicare savings program. I get extra help. I'm not sure. I don't get help from any of these programs. I answered, I don't get help from any of these programs. And then I said, it says, do you want to see your drug costs when you compare plans? Yes, I absolutely do. And I would encourage you to definitely get costs from both retail and mail order pharmacy, especially if you know you're going to be on a specialty drug, which most cancer drugs are. You likely may have to use a specialty pharmacy or a mail order pharmacy. So you want to be sure you're getting those costs there. So then I put in your magic drug, which I never can say. So bear with me when I say Imbruvica, which I think is right.
Yes.
And
Perfect. That was like an old pro. Go, Christina. Making it.
We always call these drugs yabba-dabba-doomumab. That's what we call them at Oncolink. So then you would add that drug in, and you can add, if you're on other drugs that you want to add, you can add in your entire drug list here. And when you're done, you'd click on done adding drugs. Then you would choose your pharmacies. So here's my zip code. I chose a mail order pharmacy as well as a prescription plan or a local pharmacy. And then it makes this lovely little tool for you. It tells me that there are 33 prescription drug plans available for me in Philadelphia. You can then go over here to filter your plans if you want, but I just chose to sort by the lowest drug and premium cost, which is this plan here, the Clear Spring Health Premier RX prescription drug plan. That's what PDP stands for, where my monthly premium is $13.60. And this is the estimated cost of my one drug that I put in Imbruvica, and then my deductible. But wait, there's more. Go to this part here on the website that says view drugs and their costs. And it breaks it down with each tier with this plan. So this is a specialty tier, 25%. If you're in the gap, you're paying 25%. If you're in catastrophic, you're paying 5%, or this $920 copay, whichever costs more. And then again, it shows you the Imbruvica costs broken down. And even more, it shows you what you will pay every month. So in that first month, you're going to have that deductible. So you're going to be in the donut hole. You're going to be out of the donut hole because in February, you're in catastrophic coverage, and you're in catastrophic coverage for the rest of the month, or for the rest of the year. This was so very telling to me. And also, by the way, this doesn't include, you're paying still $13.60 a month in your premium, but your Imbruvica is going to cost $663.10 for the rest of the year with that plan. Any questions about using that tool? I went through that kind of fast, but I just do want you to know, for transparency's sake, that the information is out there for you to compare costs with the drug plans. I will tell you that for the most part, they vary very little. Most drugs are going to be in this, mid to $600 to $700 a month range once you're in the catastrophic period. This is because this drug is a tier 5 drug. It's not going to be reclassified to any other tier anytime soon. And this is what we are working with this drug. Scary. So where can I get help with my medication costs? So there are some really excellent programs that might be available to you. The first, and these are all based on income. So if you are a lower income individual, and again, this is something I can do more specific work with you individually to assess whether you would be eligible for extra help, the low income subsidy. These are really excellent programs for folks who are lower income, and maybe you're only getting Social Security, you're not getting that much a month. These are great ways to offset the costs of things. We can also look at maybe if you would be eligible for Medicaid in addition to the Medicare that you have. I also just have, there are state pharmaceutical assistance programs. So in Pennsylvania, those are called PACE or PACENet. In New Jersey, it's called PAD, and in Delaware, it's DPAP. I put those 3 states because that's where I am. But pretty much every state has one. I will tell you, for my people in Florida, I'm so sorry. The prescription drug program in Florida really stinks. But we could look at individually if there are plans available for state pharmaceutical assistance. A lot of times these are funded by, like in Pennsylvania, it's funded by the lottery. It goes straight into pharmaceutical drug assistance for seniors. In New Jersey, it's not just for seniors, but also for the disabled. So we can look at some of those specifics state by state if you folks feel like you might need help, and we can do that on an individual basis. Also want to highlight, and this was something I did make a note of, that 84% of you said that you were not getting copay assistance. So I definitely wanted to highlight this as a potential resource for you. Copay assistance is financial assistance with copays for patients with insurance. That's all of you, or most of you. None of you responded that you were uninsured. But clearly, with drugs costing as much as they do, many of you are underinsured. This means that you have out-of-pocket expenses that are not covered by your medical insurance that impact your financial well-being, as well as potentially your access to care. These foundations are all managed and administered privately, and they are funded primarily by pharmaceutical companies. This is sort of the great workaround for pharma. These foundations are fairly new. Maybe the oldest one that I can remember, and some of you may be familiar with it, is the LLS, the Leukemia and Lymphoma Society, was really the first organization to start a copay assistance fund, and that was in the mid-2000s. Now there are 6 or 7 different foundations that offer copay assistance, not just to cancer patients, but folks with all sorts of diseases. But the funding is really determined on when they get paid, when they get donations from the pharmaceutical companies, it becomes a tax write-up for pharma. It was easier for them to give money to a private foundation than to supply people with free drug, because then they got a tax write-off for it. So that's really rough. So do you know how the VA—
Do you mind if I jump in? I'm so sorry, Christina. Do you mind
No,
if I just jump in for one quick second to let folks know that we just sent out, Michelle, I think we sent out information about this, that the LLS fund just opened and WM is included. And we were encouraging people last week through multiple emails to get on that as quickly as possible, because traditionally those funds are limited, meaning they will run out. So jump on that if you can. Christine, I'm so sorry to interrupt. I love what you're doing.
That
I'll
was
be
my
quiet now.
You cheated on me, so. But do you know how the VA coordinates with Medicare Part D for ibrutinib or other drugs in the family? The VA is a crapshoot. A lot of times what happens, this is just my experience with the VA, and again, this is with the Philadelphia VA, is that in order to get medications from the VA, you do need to be registered with the VA. I don't know about levels of service connection in terms of cost related to what your drugs would be through the VA. But also typically a VA physician usually needs to write the prescription for you to be able to fill it through a VA pharmacy. So that's what I know. I do encourage folks, if they have VA benefits, 1000% to investigate if the coverage can come through the VA pharmacy, because it is definitely a really, and thank you for this. I'm going to put that in my other slide previously about cost saving for vets. It's definitely something really, really helpful to have. Okay, let's see. So thank you, Lisa, for stealing my thunder. Copay programs for WM. There's 2 of them that are currently open, LLS and the PAN Foundation. They each have their own eligibility requirements. I think they're maybe both at 500% of the federal poverty limit, which is actually a really generous amount of money that you can make or your family can make. And then you have to have WM in order to qualify for this program. I cannot echo Lisa's statement strongly enough that these funds are literally opening and closing every day. So 2 weeks ago, the LLS Myeloma Fund opened, and I do the Philly Myeloma group. I got 70,000 emails. Oh my God, what am I gonna do? And don't you know, the Myeloma Fund opened about 10 days later. I do referrals for patients with all disease types. I had a breast cancer fund open a couple weeks ago. It was closed within an hour and a half. So there's just no predictability to this. And so it's really, really important for you. If you can get on it and you're eligible for it, I definitely would recommend that you do this. So I'm seeing, Ross, that you put in about the AARP Medicare. Remember too, I just want to caution you with this. This is all based on location too. Like I put in my, my zip code. And so yes, Ross, I'm sorry, you shared this just with me. So I'm going to read what you wrote. The AARP United Medicare Healthcare Medicare RX Preferred is $78.70 a month for premium, up to $87.20 next year, and $489.05 monthly for the refill. So just remember that everybody's is going to look different, because these plans, these Part D plans, are sold locally or by state. So I'm not sure what state you're in, Ross, and so that's a great option if you're in the same state as me, but everybody needs to do the work and look at the plan specifically about what the costs are going to be in their area and what's available to them.
That's at the Penn Pharmacy.
Okay. So my comment on that too, Ross, is that you are paying a whole lot more on the front end,
Yes.
like versus the example that I showed you, which was the $13 a month. And I just FYI, that plan that I put in, I did choose the Presbyterian Pharmacy, which is also a Penn Pharmacy.
Yeah.
So it's a great example, because I think it just shows that you need to shop around and do the math. And quite frankly, I hate math. It was never my jam when I was in school. But I can't tell you enough that even just crunching these numbers is really, really important to do, to really have an understanding of what your out-of-pocket expenses are going to look like. Thanks for sharing that, Ross. Okay. So just a little more on copay assistance. Like I said, each foundation has different rules for eligibility, which are both income and diagnostic. They also decide which drugs they want to cover. I was talking to a client earlier this week who has myeloma, and she was on the LLS fund. It closed. She needed to get on another fund, and they would cover Xeloda. No, not Xeloda. Xgeva. Sorry, so many funny drug names. Xgeva, which is for the prevention of fracture and for bone loss, but they wouldn't cover Iridia under this copay fund, even though they're in the same classification of medications. Iridia is actually cheaper than the Xgeva, but does anybody want to wager why they wanted to cover the Xgeva and not the Iridia? Because the pharmaceutical company that made Xgeva was funding the copay assistance fund. So that really does impact, again, what list of drugs might be covered. So each foundation then determines the amount of assistance available for each disease type. Again, like I said, they open frequently and close frequently. And some foundations, like the LLS, do also offer assistance for premiums and sometimes deductibles. So if you're looking right now for a Medigap plan and you're concerned about the premiums, maybe you qualify for copay assistance through the LLS that will help with the cost of your premiums as well. So that can be a real big help in that space too. The other thing that you may see if you have a commercial plan or employer sponsored plan or an ACA plan are copay cards. These are not for people with Medicare. These are not for people with government insurance. They're supplied specifically to the by the pharmaceutical company to offset the cost, and usually brings the copays down to like, $10 to $50. Medicare guidelines are what keeps us from being able to have copay cards be available to people with Medicare. Maybe something like that will be changing in the future if we change the way that Medicare pharmaceutical negotiation works. So other plans, I just mentioned employer or union provided plans. Those are again tied to employment. Usually our employer and employee share the cost of premiums. Our plans are dependent on the contracts negotiated between the employer and the insurer. The trends that we're seeing here are definitely premiums are going up. I love to give this example, and you've probably, if you came to my talk last year, you probably heard it. But when I started working at Penn Medicine, which was in 1996, they actually paid me 17 cents a paycheck to have the Penn Medicine plan. Now I pay about $60 a paycheck for my premium. So just that's about a 20, geez, how long have I been there now? 24 years. I've gone from getting paid 17 cents to paying about $120 a month for my insurance. We're also seeing trend-wise, lots of higher cost sharing and these high deductible plans. I had a civilian contractor employee at the VA who had a non-VA insurance, family of 6. So the premium of $300 a month for 6 of them was super attractive, but they didn't read the fine print, which was that it was a $12,000 deductible. And so when the gentleman in the family got sick with lymphoma and was getting bills for $12,000, he thought, wow, how did this happen? He hadn't read the fine print about those high deductible plans. So definitely something that I encourage you to do if you're thinking about your plans and thinking about open enrollment.
We have another question also.
Okay.
Does the exception for drug discount cards for Medicare recipients apply even if you're only on Medicare Part A?
Does the exception for drug discount cards, you mean the copay cards that I was talking about? No. Well, you have to have, I guess I have a question for you, Janet. Do you have commercial pharmacy coverage through either your spouse's employer or through your former employer? because that's the only reason I could think of. Yes, current employer. Yeah. So you're still working, you're eligible for Medicare, so you have Part A, but you're still working. Likely, if as long as your insurance coverage is a commercial plan, it's not a Part D plan, Medicare plan, likely you would be eligible for copay assistance cards because you have a commercial pharmaceutical plan. Good question. You guys are so good. You always make me think so in depth about these things. And I so appreciate this. So the Medigap plans or Medicare supplemental policies, they help to pay the costs of things that Medicare A and B don't cover. Again, just like Part D, these are sold by private companies. The best time to enroll is when you are first eligible. This is called your initial enrollment period. This is because outside of that period, they can charge you more for pre-existing conditions. Usually they have a time stamp on the coverage that they sell that says, okay, we will sell you this policy, but we're not going to cover any of the costs related to this disease for 3 months, 6 months, 9 months. Then after that, they may cover it. The premiums are also higher for tobacco users. Your initial enrollment period, hang on, too many windows open. Let's see where I did that. Okay, first of all, let's look at the plans. This is my little magic chart. Somebody mentioned earlier about Part F. Not only is Part F no longer available, but Part C is no longer available. That happened at the beginning of this year in 2020. They weren't allowed to enroll any more folks into Part C or Part F. And again, I just want to say, because the government is so incredibly creative, that these A, B, C, D, these are completely different from the A, B, C, D we already talked about, okay? This is only for this Medicare supplemental plans. The reason that they had to stop selling C and F plans was this, the Part B deductible, which Part C and Part F covered at 100%. The federal government decided that wasn't okay anymore. And so that is why those plans are no longer sold. So just an FYI, that Part B deductible is $183 per year. And you certainly can buy other plans like a Part D plan or a Part G plan that cover, I mean, G is certainly the most comprehensive compared to an F or a C. The only difference is you'd have to pay that Part B deductible. Now, a lot of folks who are in a C or an F plan are asking me if they should switch. And I want you to think about it and price it out, because the issue is that with not enrolling any new folks, their risk pool is getting smaller. So their premiums may go up at a higher rate than the other plans, just because they're not adding new covered persons into their risk pool. So yes, Don, if you're on F, you can continue it as long as you were on it for 2020. But I would definitely compare the price, because like I said, they're not going to be enrolling any new folks into those plans, so your premiums may go up. So I don't foresee a closing of G plans in the near future, but I also didn't foresee them closing F and C. They may try to nitpick, who knows? But right now I'm not hearing about any of that, and it's certainly they're selling them for 2021. So one of the things I also like to highlight here is that if you do like to travel, that some of these plans like D, G, M, and N also have a foreign travel emergency coverage built in. And I will also tell you, and this came up for me in a case I'm working on with one of my students, if you look across the top line here, Medicare Part A coinsurance and hospital costs up to an additional 365 days after your Medicare benefits are used. So I'm working on this case with a student of mine who has a patient who has now actually used all of her lifetime reserve hospital days with Medicare. But because she had a gap plan, and it was a Plan F gap plan, she has it potentially up to an additional 365 days of Medicare inpatient hospital days beyond that. So this is just another thing that, to me, makes having a gap plan a really attractive thing for folks. Like, that's what I advise my folks on. I said A, B, gap plan, D. And my folks are fairly healthy. In the cancer world, we tend to refer to Medicare Advantage plans as Medicare Disadvantage plans, mostly because you don't get some of these benefits like those extra hospital days that you would get with the Medicare supplemental. And certainly plans that I've looked at, you know, the premiums can run from, you know, $100 a month for a Part A Medicare supplemental to the highest I've seen is around $600 for a tobacco user in Texas. That is still less than a $7,500 out-of-pocket max that you might be seeing with a Medicare Advantage plan. So again, I say, my favorite thing, you have to do the math. So when can you buy? I mentioned that initial enrollment period that begins the month that you turn 65 and that you elect Part B. That's a really, really important thing, that you've elected Part B. It then continues for 6 months. This is your best time to buy because they cannot use medical underwriting or charge higher premiums due to a pre-existing condition. Then you can also buy during open enrollment or outside of enrollment periods. But again, those are times when they can employ medical underwriting and can say, well, we're not going to cover this disease, or we're going to give you a higher premium as a result of your pre-existing condition plans. And this is the one area where Obamacare pre-existing condition clauses did not apply, is to Medigap plans. So pre-existing conditions are alive and well in this space. Okay. So there's also a little bit more of a caveat. If you're not 65 and you become eligible for Medicare, maybe you're disabled and you become eligible for Medicare after 2 years, federal law does not require insurance companies to sell Medigap to individuals under the age of 65. Kind of puts you in a pickle, because usually you're allowed to buy a Medicare Advantage plan. And I see a lot of younger folks who aren't 65 get into Medicare Advantage plans to help with the costs of their care. But in reality, it's a really difficult position for them to be in because they're having to pay these high maximum out-of-pockets. Some states do require companies to offer coverage to those, but it can cost more and premiums can be adjusted based on your age. So something to keep in mind for all of our youngins here. So what if you have coverage? Wait a minute. What if I have coverage? So you're looking to buy a gap plan. This was your question earlier, Janet. So your work or union coverage is going to be primary. If you elect Part A, just like Janet did, that's going to be secondary. In those cases, and Janet, I'm hoping maybe this is what you did, you may want to wait to elect Part B. Because as soon as you elect Part B, your time period to get a gap plan without a pre-existing condition clause, it starts that day that your Part B coverage starts. So I tell folks, if you've got what you need through your work or your union coverage and the Medicare A is a secondary, you might want to hold off on the B. You probably don't need it. And then you have to buy a gap plan really within that first 6 month period of time, or you're going to be on the hook for pre-existing conditions afterwards. Does that make sense to everyone? I know it's a little confusing. Okay. A little bit about ACA plans. Right now is open enrollment for the ACA. I'm going to take a swig. I'm not ready for my house to be so incredibly dry yet, and it's so nice out. Yes, waiting on B and gap decision until I'm no longer working. Good job, Janet. Excellent work. So the ACA plans, they offer 4 plans. Thankfully, they're not A, B, C, D. This time they're actually bronze, silver, gold, and platinum. Your platinum plan is for your risk-averse person like me who's going to pay more at the onset for those monthly premiums, but pay less when I actually need care, all the way to your bronze folks who are going to pay less on the front end, but more on the back end if they get sick and don't plan to use or need a lot of healthcare services. But that's the kicker, right? How do we really plan or know we're going to need healthcare services? The other difference with these plans is their cost sharing. So a platinum plan cost sharing is 90-10, and a bronze plan is 60-40. So while you may be paying less for your premium, you're certainly going to be paying more out of pocket when you actually access care because of that cost sharing amount.
The question.
Yeah.
No. More women are getting diagnosed earlier. Do you have any creative ideas of how they can get coverage if they are no longer working due to treatment?
Just to jump in there, it's WMers. I get this question a lot from support groups from younger WMers who are trying to figure out how to.
Okay.
I mean, the big thing there, Lisa, is going to be, are they still working? If not, is COBRA an option, or is coverage through a spouse an option? And then if they're not working, probably would have to get creative with thinking about what income sources are and what their coverage is going to be. Maybe they're going to buy a plan through the Affordable Care Act, through Obamacare, and we'd have to look at what pharmacy coverage might look like for them in that space. It kind of would be on a case-by-case basis with all those variables. Does that help you, or does that make it worse?
Super helpful. Thank you.
I never want to make it worse. So the Obamacare or ACA plans differ in terms of what their out-of-pocket expenses are, just like I told you with the difference between the bronze and the platinum. They also all have these networks of participating doctors and hospitals, and the networks can actually be pretty small. So it's important to know, especially when you have a rare disease that really does require specialist services, that they're going to be within network. And a lot of times what I will advise folks to do in those situations is to call the financial services or business office at the facility where you're being treated and ask them for a list of the providers that they are in contract or in network with for ACA plans in their area for the upcoming year. They will provide that for you. But the prescription drug coverage can also vary quite a bit, Lisa, for some of your younger folks who might be going through ACA in terms of which drugs are covered, again, back to tiers. And this one is the kicker that really kills me, that some plans have separate deductibles for pharmaceutical and major medical, which can be a double hit in the deductible. So I'm really, really advising folks to ask that question specifically when they're enrolling in a ACA plan. Is the pharmacy deductible included in the major med, or is it separate? And if it was separate, I would probably look at another plan. So this is just a listing of who can buy a plan. You have to live in the US, be a citizen or lawfully present, not incarcerated. You can buy an individual or a family plan. Individuals who work for employers with small businesses with less than 50 full-time employees can buy. And then built into the law are these really generous premium tax credits and cost sharing available to those who meet qualifications. This is one of the things that is really, really at risk in regards to the Supreme Court case that's coming up and whether that is constitutional or not. So let's talk about the Supreme Court case. On Tuesday, Supreme Court will be hearing California versus Texas, which is not the first time that the ACA has come in front of the Supreme Court. This has been a goal to dismantle the ACA since it came into being. I went to a webinar about 4 weeks ago. They outlined 4 possible scenarios. One of them I've already taken off, which is number 2, as that was based on whether or not a new justice was sworn in. That has happened. So the court is now a 9-person court, not an 8-person court. So there's basically three things that can happen. And I just also want to preface this by saying, this is not going to happen this week. They are hearing oral arguments beginning this week, but likely the Supreme Court will rule on this case in the spring. And so these are the options that were outlined for me. One, that the court rules in favor of the defendants and finds the ACA constitutional, which would leave the law in its current state untouched. Number three, being the current court rules in favor of the plaintiffs and finds mandate, the tax mandate, the individual mandate, which says you must have insurance. And if you don't, you have to pay a tax on it. They want that to be declared unconstitutional. By the way, it's already gone. It's been gone since the beginning of this year as part of the administration's tax cuts that they had. So nobody's actually being charged a tax, but the language of it being in the law is still what is problematic for so many people. So if that happened, then some provisions of the ACA would need to be removed from the language. And finally, number four is that the court rules in favor of the plaintiffs and rules that the entire ACA is unconstitutional, which would invalidate the law completely. This is sort of my nuclear option here. And I'm hopeful that that is not going to happen because there's been so many precedents already in Supreme Court cases that have upheld so many other parts of the law that hopefully that is not what's going to happen, but remains to be seen. As I mentioned before, it is so much more than just about people being able to buy insurance that couldn't buy insurance before. Obviously, and I saw this in all of your questions, what's really at risk for us are these protections for pre-existing conditions. It's really the most popular part of the law, but it's also probably one of the hardest parts of the law. And the reason I say that is because we need healthy people to balance out the sick people. And if we have a unbalanced teeter-totter of a whole bunch of sick people, the law and the provisions of providing insurance for folks who are sick can't continue because we don't have enough healthy people to balance it out. Also at risk are bans on lifetime and annual caps. These were alive and well up until 2010. I worked with many, many patients who had lifetime caps of $1 million. And if you needed a bone marrow transplant, like many of my patients did, they reached their lifetime caps with that insurance and then were forced to needing to find other insurance. Oh, and they had a pre-existing condition. It was impossible for them to do. Also at stake is coverage of our essential health benefits, and every single one of us, all 55 of us that are here today, have experienced a benefit of an essential health benefit, whether it's an annual checkup with no copay with our physician or our provider, our screening mammograms, screening colonoscopies, mental health is an essential health benefit. All of that could go away. Maybe you're a parent who has kept their child on your insurance plan up until the age of 26. That goes away. The expansion of Medicaid, which has now happened in 37 states and opened up insurance to millions of more people through that Medicaid expansion, goes away. The individual mandate goes away, and the closing of the donut hole, which is going to impact all of you in terms of your drug costs, is also going to go away. So it's really, really multi-layered. So what does it mean for 2021? The ACA today, November 8th, is the law of the land. Open enrollment has started, plans are being sold. What is unclear to me, and I wish I had a crystal ball or at least the magic 8-ball to give me a sense of what might happen, is what happens if the law is struck down, because there is no off switch. This took years to implement, and it likely will take years to unravel. And so I'm trying to get folks to understand that even if it's March or April and the Supreme Court says the law is unconstitutional, that doesn't mean the next day you're going to lose your insurance. And clearly the election results, and Lisa and I have talked about this, I'm trying not at all to be political, but the election results are going to have an impact on future health law and policy. So even if the ACA is struck down, As a result of the election, there may be something new coming down the pike. The other thing I like to tell people is that thanks to coronavirus, we now have probably 10 million people who also have a pre-existing condition that they didn't have last March. So we have got to get this figured out, because what we're learning about this diagnosis with this virus is that there are lots of long haulers and people who have long-term effects. And so we're talking about, again, adding more sick people to a risk pool without balancing them out with a healthy people. So what do we do to prep for open enrollment? Know your plan. That was your homework assignment that we talked about earlier. Getting to know your plan. You can always request your plan from your provider. And now, because of the internet, most of us can download information about our specific plan pretty easily and readily with the tip of our fingers. I also have a really good resource called the Cancer Insurance Checklist, which I'm going to put in the chat box. This checklist is the brainchild of a bunch of different cancer service organizations and is a great free tool to help you understand and kind of take stock of what you need and what you have. Okay, so that's that list there. And also asking for help is something that can be really important. Who can you ask for help? Well, you can ask your social worker at your treatment center. You can ask financial navigation at your treatment center. Sometimes they're called navigators, sometimes they're called advocates, sometimes it's called financial services. You can get help, more help from me through the Cancer Support Community Helpline, and I'm putting that number in the chat box so that you have it. And if you don't have this number anyway, it is a great resource for all things resource related when you're coping with cancer. You know, whether you want to find local support services, you want to find a summer camp for your kids to go to, you want to get a therapist close to where you live, you need help with utilities, or you just really need somebody to help guide you through more of your insurance stuff. We also have specialists like me who do genetics, who do clinical trials, and who do pediatrics. So we have a really wide range of services available. You can call up, they'll do an intake with you on the phone. And then if you need more financial navigation services, they will refer you to me for more of that individualized service. Let's see. Then also a lot of times folks will ask me about medical fundraising, the GoFundMes or crowdfunding or crowdsourcing. Certainly this can be a huge help. I gave a couple of weeks ago to a fund to support the family of a Black man in my neighborhood who was shot by officers during a mental health crisis. It was really meaningful for me to do that. And they've raised like $300,000 for this family in about 2 weeks period of time. I use that as an example though, because they originally set out to raise about $25,000 and now they've got a lot of excess funds and no real plan about who's getting them, how it's being dispersed, and no real transparency either. And so I think this is something that a lot of folks who start GoFundMes are looking to pay for specific things, but then maybe they get more money than they need and they don't know quite what to do with it. It doesn't affect your income in terms of things like Medicaid or SSI benefits. These are considered gifts. Medical fundraising donations that other people make to you through a GoFundMe are also not tax deductible because you are not a nonprofit. But to really get it out there and get the money raised that you might be looking for to pay for the cost of your medications, it requires an all-out social media blitz. And if you're not comfortable with your story getting out there or people sharing things about your medical conditions or personal stories, it's probably not the space for you. So just a couple of things to take away from medical fundraising. Again, a couple more folks who can help you with navigating. I mentioned financial navigators and advocates and social workers. There are also state health insurance assistance programs. These are called SHIPS counselors. And if you just do an internet search for SHIPS counselors in your area, they'll provide you with a linkage. There are some ACA navigation services available. These were cut back by the current administration, but if you go onto the ACA website, healthcare.gov, you can find assisters, and I encourage you to look for language assister versus broker, because there we go to the brokers who, again, remember, brokers want to sell you a plan because they get a commission based on whether or not they sell you a plan. So if you're looking for navigation assistance with the ACA, I definitely encourage you to look for an assister rather than a broker. And here's just some more resources for you. OncoLink, that's where my day job is. We have an excellent health insurance webinar series that I just updated for this year. I'm going to put that link in the chat box as well. Let's see. This is what happens when I try to type and talk at the same time. I don't spell particularly well. That's available at www.oncolink.org/insurance. There's 6 different modules that break down Part A, Part B, Medicare Advantage, GAP, Part D, and COBRA, I think still. We have a lot of good options there though. They're free. It's a little bit more of a deeper dive than what I did with you here. I mentioned that Medicare.gov is actually a really, really well done government website. Encourage you to use that tool. Also to download the free publication that is called Medicare and You. They update it every year. I read it every year. That's where all of the good information is about what's happening with Medicare in the coming plan year. Healthcare.gov is where you want to go to for anything for ACA. Medicare Interactive also has a tool within it called Dear Marcy, where you can ask questions that you might have specific to your Medicare coverage. And I also saw in one of the questions that was submitted about specifics with Medicare and federal Blue Cross plans. So I put that link on there for whoever asked those questions leading up to this. There are definitely some specific rules and things to think about when it comes to marrying or not marrying your Medicare and your federal Blue coverage. So it's a good resource that's available there. And then finally, Triage Cancer is a national nonprofit that provides insurance and financial education and resources to folks. So those are some resources that I have for you. This is my information. You can email me at either the Penn Medicine or my cancer support community email. Call the helpline if you're looking to get a financial navigation referral. Those are some of the closing points that I have. I'm happy to take questions from you now. I think, Lisa, we're doing great with time.
I'm amazed. I can't believe how much you just did, and I understood it all. And I'm so sorry to steal your thunder about LLS.
Oh, it's all right. I'll let it go.
But you know, my dear friend, you are the thunder, so there's no way I could steal anything from you. You bring the thunder is what you do. Okay. Christina, thank you so much for your wisdom and guidance. Your ability to unpack complex material with such warmth and humor is such a gift to all of us cancer patients. And today we're so grateful to have enjoyed some quality time together this afternoon. You've given us all a healthy dose of education, information, clarity, and a lot of homework. I'm actually going to go home and do some of this. So please know that we're ever grateful to you. And I don't know if you're willing to entertain questions for the next couple of minutes or see what's on folks' minds, or would it be okay with you to hang out and see if anybody has anything ongoing? Yeah, I'll just say that
we did have one question, which is where is the recording going to be posted? That's one question.
Oh yeah, so that's a great question. Two things will happen. This will be later on in the month. We will send this out to IWMFers, probably in an e-blast saying this is now available. It will be posted on the IWMF website. And what I was going to do was send you guys the resources that were put in the chat box so that you'll have those. So in case you spelled anything wrong or didn't catch something off one of the slides, Christina has the best resources. So I want to be sure that everybody gets all of those properly. So we'll be sure you get that. We're also going to send you out a quick 2-minute survey this week asking you about today's meeting. And please be honest so that we can, constantly improve our programming. But Christina, there's nothing to improve with you. So what can I say?
I'm just so grateful. You guys ask amazing questions leading up to this session and are clearly thinking about all of this and its potential impact on you. And our systems are pretty broken. But the best thing that we can do is just have some knowledge. I always say knowledge is power. And so that's the best thing I can do is help you to get that knowledge and know what you need to have to navigate the space. I just want to alert you to the dogs just woke up. So
Yay.
They may I'm gonna stop my share so I can see people's faces, if that's okay.
Oh, good. We've got Veronica's got a question here for us.
Awesome. Hi, Veronica.
Hey, hi. I have a question. My former employer just sent us out notice that they automatically changed our, okay. We have, they changed us from the Care First Medicare supplemental plan to Aetna Medicare plan with extended service area.
Okay.
We have no say. We just got, okay, here we.
Yeah, that and anytime you have an employer associated Medicare or Medicare supplement, the rules are always going to be what the employer has, and remember, they're shopping around too, right? And they're trying to find the best price to ensure the maximum number of their retirees. And so they shop around just like I would tell you to shop around in the individual market to find what that is. But you're right, you're kind of at their will. That being said, those plans, those types of employer plans are such a rarity anymore, and their benefits can be better. I will tell you that. So I would definitely just spend your time doing the homework with the new plan and getting an understanding of what is covered and how, maybe even comparing the two, just so you have a good understanding of that.
Okay, thank you. Thank you.
We do have a question from Greg.
I've got a question.
Okay, hang on 1 second, Gary. I'm just looking in the chat box.
Oh, good.
All right, so you have somebody, Greg, you have smoldering WM and you're not on meds at this point, but likely will be needed soon. How do you know which drug plan? I'm assuming, Greg, are you a Medicare person? Yes, okay. So Greg, with Medicare, I would do exactly what I showed you to do in terms of going through and comparing the plans. If you know the information, you should ask your provider about the potential drugs that you may be on and the doses that you may be, so that you can price them out and do a comparison of what those costs might be with each plan. But I'll be honest with you, there's not a lot of big difference. I mean, as we illustrated earlier, the difference might be in your front end cost with your premium, and then your back end cost with your copays must be less, but usually they're coming out to ultimately being around the same amount of money. If there was one Medicare plan that was cheaper than all the other ones, everybody would be in it, right? And that's just not the case. So definitely need to do the homework in that circumstance. So Gary, you had a question?
Yeah, I'm 83 years old, so this is my 19th open enrollment period. And what I'm wondering about is this: why is this year? I mean, I have never received so many mailing pieces, emails, webinar invitations. Why this year?
I definitely have seen an uptick on it over the course of probably the last 5 years. And to the point that I will be honest with you, I'm a raging insomniac and I'm up a lot in the middle of the night. And there are full 30 to 60 minute webinars, or not webinars, infomercials about some of these plans happening right now. It's an all out assault, I think. And I do get concerned about the potential of our older generation who are on Medicare being taken advantage of in some of these situations because there's money to be made. So I don't know if that's it, or if maybe they were bored because of COVID and they had nothing else good to do but to make a, like the rest of us trying to make the best of what we can. But it does feel like, I mean, even a friend of mine, her mother-in-law, she's 85, and she got a mailer and she was like, oh, this sounds good. I can get a gym membership. And she,
oh my God,
without ever talking to anybody about it. So I wish I could scream it from the mountaintops someday. So that's why I'm so glad all of you are here and chose to spend your Sunday afternoons with me, because hopefully it will help you to navigate some of that space a little more comfortably. So looks like we have a question.
Can I ask a question?
I have one other person in front of you, Erna. Can I ask if Stephen has a question, and then I'll come back to you, Erna? Thank you.
Okay.
Yes, I just had to switch on my Part D for medications, and because my other company just dropped local drugstores.
Mhm.
And this new one does not have a pharmaceutical, and I'm told that the next possible medication might be ibrutinib. So might there be problems just getting it from, if there is no mail,
They don't have a mail order pharmacy?
they don't have one connected, because that would not normally make any difference because I never use it, that kind of service.
So, this is where you guys, I might need to tap in on some of your expertise as well. Does
That's the
ibrutinib,
same as the ibrutinib, and Imbruvica is the same thing, Christine.
yeah, do they have, so, sorry, we're getting frisky behind me. So if you hear some howls, I apologize. So do they have, there are certain specialty drugs that have actual specific pharmacies, specialty pharmacies, that they can only get their drugs through that. Is that the case with Imbruvica? Does anybody know? Sue's saying yes. So in that, yes, and Betty's saying yes. So in that case, Stephen, that's a distribution issue regarding the drug. And that's where your drug company needs to work with this specific supplier for that medication in order to facilitate you getting it. Since you can't get it at your local pharmacy, they would have to work with them on that.
I can
So,
say that we've worked with Biologics. I think that's the company that okay, and Betty's nodding yes, because we had sent IWMF brochures to them. We've been working with them to make sure, Stephen, that our information is getting put in those Imbruvica new patient packets that have been sent out. So Biologics Incorporated is the company that I'm aware of.
I love the sharing of good knowledge. It makes me so excited.
so, okay, so that doesn't make any difference then whether it has a mail order.
No, it really, I mean, then it becomes that the distribution of the specialty drug is sort of what is the deciding factor, and then they will work to bill your payer. And that's just something that comes down. Certain pharmaceutical manufacturers only want to work with certain specialty pharmacies. So it sounds like that's what's happened with Biologics, and it is helping in terms of like that specialty pharmacy really being skilled at managing that specific drug and making sure they can get that to you. But I would definitely work with your pharmacy team at your physician's office as well, because they will be helpful for helping to work through some of those processes as well.
Seems like Betty Walters, she's been kind of nodding her head. She seems to kind of know. I don't know if you want to unmute yourself, Betty, and share some insight if you have experience. I don't know if you can unmute yourself, or Stephen, to give any insight.
Sure. I'm the one in Kodiak, Alaska, and mine comes from the same person or the same pharmaceutical company that was mentioned. And they're wonderful, but the order goes in from your own physician, your specialist. So that often put all the paperwork through. They will contact you. They're amazing. And then they will contact you once a week, the first month that you're on the drug, and every month after that.
Yep.
And you can contact them 24/7.
Yeah, specialty pharmacies, the ones that do it well, they're really, really good. So thanks for sharing that experience with that, Betty. And like she said, Stephen, your provider's office is going to send everything to them, and then they'll coordinate the delivery of it to you. Okay, Erna, you had a question next, and then I have a more in the chat box.
It's two parts, really.
Okay.
I have a supplementary gap plan that I pay about $300 a month. Does that fall within the average that you would expect?
Yes.
Okay, and also my plan is a Plan E, which is I'm grandfathered. It's a AARP United Healthcare, but it's no longer available.
Okay.
Plan E.
Correct. It's not even on that chart I showed you anymore.
Exactly.
Mhm.
So the fact that I'm grandfathered, does that fall into that risk pool issue that you mentioned?
Yeah, potentially it could, because again, they're not selling Plan E anymore. So that smaller group of people, it's getting ever so smaller every year. So that your premiums could go up. You may want to shop around and see if you can get a better cost with a different gap plan during open enrollment.
But stay with the AARP United Healthcare?
Not necessarily. I mean, you may go onto the Medicare.gov website and there may be a plan. Oh my God, I'm losing my numbers again. G, that's, $250 a month and might be the same coverage or whatever. I mean, you just kind of have to think about, what do I have now with Plan E? What can I think about if I wanted to change plans? Because certainly that premium could go up based on the dwindling size.
Well, it goes up every year a little bit, but it doesn't seem to be out of ordinary increases.
It's kind of one of those situations where you're rolling the dice, right?
Yeah.
Yeah.
And what does capitated mean?
Capitated means that it's basically a network of labs. Usually we hear that terminology in labs or in radiology. So like the big labs in the United States are Quest and LabCorp, and they have contracts with a lot of different insurance companies that basically says, this is where you have to go to get your labs done. Otherwise, it's going to be out of network, because they've negotiated a specific contract with that provider to provide all of the labs for all of the people that are insured with that plan. Otherwise, you're out of network. So you want to always be sure that you know where you can get your labs done within your network.
Thank you very much. This has been great.
Yay, thanks for being here, Erna. Okay, we had one more question from Dawn. Is there any reason that being on both Medicare Part D and an employer's retirement medical drug plan could be disadvantageous in terms of cost? Yes. That it's almost like I'm overinsured. How much do I really want to pay here? I'm always going to tell you too that if you have the option to have a retiree medical and pharmaceutical plan, that's probably going to be better than just going through a gap plan and a Part D plan, because again, your employer plans have negotiated rates with these insurance that our government hasn't done with these private companies that are doing Part D and the gap plans. So I don't know that you need to have both. There are special circumstances in terms of if your spouse is still working and how Medicare works with that if your spouse is still working. But if you have coverage through an employer plan that includes medical and drug, you probably don't need Part D at this time.
Okay. Hey, Christina. Yeah, this is Don. Thank you. I actually have some special circumstances with the retiree medical access plan being necessary, even though it's definitely overkill in terms of healthcare cost, because of some special provisions in it that cover one of my sons. That other health insurance plans and Medicare would do nothing for. So I actually have to have that.
Yeah.
I didn't want to de-enroll from any Medicare plan. I may be beginning treatment with these expensive medications. I don't even, within the next few months, I don't even know for sure which medication I'll start with.
Okay.
So the point is I have to be on the retiree plan.
Okay.
I didn't want to get off Medicare Plan D, and I'm also on a Plan F Medigap, because I don't know who's going to pay for what. And
that's actually my question for you is who's going to pay for what?
I don't know. I mean, I do know what those plans are, but without knowing a specific drug, I
just wonder, like, who's the primary payer in this point? Is it your retirement plan?
Medicare.
It's
Medicare primary.
Okay. I think, where I have my concerns is how that Medicare Part D is going to play in the sandbox with your retiree medical plan, if at all. And I don't know the answer to that question without knowing more of the sort of specifics
Yeah.
of how that
Okay.
happened. But
All right.
something to give me pause to think about and to look into a little bit more.
Okay, yeah, if you don't mind, what I'll do is send you an email with some background.
That'd be
And
great.
then you don't have to, do all the research, but if you can at least do enough to refer me to to tell me who I ought to talk to based on my circumstances,
Sure.
that would be great.
And where are you located, Don?
I'm located in Los Gatos, California.
Okay, great. I'll see what I can figure out for you. Let's email some more for sure.
All right, thanks a lot.
Awesome. Thank you. All right, Lisa, I think that's all the questions I have in the chat.
That's amazing. I can't thank everyone enough. One thing, if you are new to the IWMF and this maybe was a first support group experience for you, I would love to invite you to contact me so that I can, or Shelly at the office, and we will send out our emails after this so that you can feel connected. Let's talk. If you've never done anything with the IWMF before, if you like this support group, want to find out what's in your area of the country, talk to me and I will get you connected and hooked up, and you are now a Walden friend. Most importantly, unmute yourselves and please help me give a huge round and a hoot and a holler applause for our amazing Christina Bach. And love from across the country. Alaska and beyond, Christina. I hope you feel the love.
And Eugene decided to join us to clap with us.
Welcome, Eugene. So, folks,
he says, and kudos to all of you for doing this work. It's hard enough being a patient, but to have to do on top of it. I know, and I'm glad I could be here today to help support you through some of that stuff, and know I support you through what you're going through.
You just made it so much easier.
Thank you. All right. All right, Lisa, is it okay for me to stop the recording now?
Please do. I'm going to hang out here